Last week, a lot of things happened. There was an Asian Myeloma Network meeting. I was also part of it. We were talking about B cell maturation antigen, bispecific antibody-based therapy, and the infection risk around it. I hate you guys. You're making me learn oncology, right? So if you thought you guys have to learn infectious diseases, keep this in mind that we are having to learn oncology as well. With the designer drugs, what you can do is it's improving survival, but it also does all kinds of mischief that it becomes more and more complicated and nuanced in how we approach it. For example, if you talk about the cytokine release syndrome with the CAR T cell therapy and even with the BCMA, BSABs and all that stuff, and the neurological syndromes and all that. I mean, where do you say it's infection and where do you say it's non-infectious? Absolutely challenging. And a lot of it will come with enough education and experience. All right. So many of you may end up in the corporate sector. So you will see that approaches may be different. It's because of various reasons. So one is that, obviously funding is a little better in the corporate sector. So they have access to a lot more technology. Nambi is going to be talking a lot about that. So I'll try and stick to what I am supposed to do. How does this work? Yeah. I look at that. Okay, awesome. So just some references that you can look at. There are lots of updates to all of these things going forward. Okay, so she discussed this, what febrile neutropenia is. See, the problem is this. When we talk about neutropenic fever, it's not all the same. If you have a patient with rheumatoid arthritis, my rheumatologist, she gets panicky. She gives a patient methotrexate and the patient comes back neutropenic, she's like, kind of thing. I'm like, go away. Right? And then my hematologist, oncologist is like, chill guy. He's like, yeah, neutropenic kind of thing. Where are the neutrophils? Yeah, we are searching for them. The lab is searching for the neutrophils in the peripheral smear. So obviously it's not the same. So the risk of sepsis as we see it, if you look at it in terms of the incidence of febrile neutropenia, it's obviously higher in the most high-risk patients. If we are looking at AML induction, it's obviously very, very bad. But in solid tumors, the risk is very low. But also keep in mind that the mortality is also following the similar graph in that in solid tumors, if you have febrile neutropenia, the risk to life is fairly low. Unless, there's some catastrophic event that's happened anatomically or something like that. But in Hem-onc, your mortality, ascribable mortality is going to be significantly higher. And a lot of it is because the host immune response is going to be so much more poorer. Let's go. Obviously, you want to get it right as quickly as possible. Initial indirect therapy is really bad. Right? So the higher the risk, like she said, go up and then come down. You do not want to take the chance of being wrong, because very often in a high-risk situation, you do not have the option of doing it a second time. In low-risk patients, you get a second chance, mostly. But in high-risk patients, you're talking about AML and things like that, you got to be really careful. That doesn't mean give colistin to everybody. That's not what I'm saying at all. Understand a risk stratification, look at your own microbiology, to your microbiologist, and look at your antibiograms. If you have ID in-house, awesome. Get them to help you and all that stuff. I'm not going to go into this. Next slide. So I generally like a risk stratification. I understand what she said in that there's not really very good models which have come out from India, but understand the principles of it. Don't worry about the nitty-gritty of it. The principles still apply. Let's go. Why is it important? Because the degree of neutropenia obviously influences it. So less than 1,500 is neutrophils is called neutropenia. Yes, but really, if somebody calls me in the middle of the night and says 1,400 neutrophils with fever, I'm just going to say give paracetamol, take a blood culture, give whatever antibiotic you want, call me in the morning. Right? But somebody says 200 neutrophils, patient is septic, I'm going to be like, okay, wait, I need to sit up. Preferably I'd like a coffee. I need to listen carefully. Right? Very different. Okay, so how do you look at it? Low risk is basically outpatient. She said that. That point is very important because not all of it is translatable to us, because problem is options here are more complicated because we don't have that many oral options. But if a patient comes to you in the outpatient well enough, that's usually a good thing. But of course, inpatient getting a fever is never a good thing. Healthier patient, younger patient, not too debilitated, or other organ systems are working well, actually good performance situation, all of these things are good. On the other hand, you have a patient with uncontrolled disease, really debilitated, all these things, these are really bad. So it gives you an estimate as to how much time you have, and basically sometimes you have to go up a little more based on that. Right? You can argue that it's the same microbiology, but the margin you have for error is so much less when you have a very high risk patient. but then it has to be tempered with your epidemiology, right? Let's go. Oh, I can use this. Okay. So when we look at it, how do we assess a febrile neutropenia, and how do you look at your own assessment of the risk of sepsis? So each institution should produce this data. Like for example, in a more mature system which handles large volumes and has good resources, the risk of febrile neutropenia has been shown to be lower because they take a lot of proactive steps in reducing that risk. Do you understand that? It's no different from a surgeon starting surgery. You know, early in their surgical career, their outcomes may have more problems. But as they get better and better, their outcomes are going to be better. So it's true for every situation like that. So you look at your own situation. If your febrile neutropenia risk is high, that's when you start thinking of colony stimulating factors to shorten the duration of neutropenia. But understand that Cochrane meta-analysis has not shown a survival benefit for colony stimulating factors, but we still give it because we want to minimize that risk. Yes, it does reduce the risk of infection if you use it smart. Fair enough? Let's go. So always stratify it. Obviously, we know more severe neutropenia is bad, longer neutropenia is bad. Gram negatives are always worse than gram positives. I would say Candida is even worse. Also look at the underlying situation and of course the comorbidities. Let's go. I'm not going to go into this. Too long a list. MASCC score is what is, this is MD Anderson's beautiful table. I make my fellows go do this anyway because it's a good exercise, because it makes you look at all these points when you're evaluating the patient. It's not the score, it's the individual components I'm interested in, right? So I think it's a good exercise because you're actually assessing the patient in a more global sense and trying to figure out where he fits in into your paradigm of severity. Let's go. Go on. So, like she said, start by examining the patient. ID guys, you know what we do differently? We do two very rarely done things today. It's called history taking and physical examination. Everybody's running for PCRs. In the corporate setting, at least. See, academic institutions are different. Let's not go by that. In the corporate setting, everybody is running for high-tech stuff, right? We guys specialize in low-tech. We start with history. Like she said, the child next door had influenza. You can get that free of charge by just talking, right? Talk to the patient, talk to the family, find out what's happening. Examine the patient from head to toe. I generally say, don't put your finger into the rectum. Neutropenic patient, that's never a good thing. Examine the perineum. Split the butt cheeks, have a look. You want to know. Don't put your finger in. That will cause a bacteremia. Send blood cultures. Be generous. Okay. 2 blood cultures. Okay. No, okay, adult. I'm not talking about children. No person is going to become anemic by losing 40 ml of blood. Nobody is going into intractable hypotension by losing 40 ml of blood. I know everybody sees that volume of blood and the patient will be like, the blood is going kind of thing. Dude, I'm trying to save your life. For the love of God, keep quiet, right? And the Surviving Sepsis campaign has shown that adequate blood cultures is an independent marker of survival. So please, take blood and do it correctly. Clean the skin. See, the problem is coagulase negative staph is a major player here. And especially with indwelling foreign bodies, you do not want skin contamination. So please make sure you prepare the skin properly. If you have staff doing it, train them properly so that your culture contamination rates are absolutely non-existent. Does that make sense? It's important to do this. 2 separate pokes, 20 ml from each one. If you have a line, we want to take it from the line. Okay, 1 peripheral poke, but clean, please, for the love of God, clean well. Okay, next. Of course, all the other stuff. So, okay. So blood culture from all lumens, well, that's too expensive. At least get it from 1 lumen. Right. Peripheral culture, definitely I'd advise that. Urine culture, you got to be careful because unless the urine is collected carefully, it is going to be junk. And urine analysis is useless. Why is urine analysis useless? Why can't we do a urine analysis? You're expecting lots of puzzles. Okay, but urine analysis, I'm not talking about culture. Urine analysis. You know, they send it as when they say sugar, protein, white cells, red cells, all that stuff. Why is it useless? The person doesn't have any neutrophils. What are you going to find in the urine? Pus cells are neutrophils, right? He or she doesn't have neutrophils. Don't look for it. You're not going to find it, right? So the worse than your neutropenia, the more or less like I beg your pardon? Culture is useful. Useful if you're thinking of urinary focus. But remember, unless it's done carefully, you're going to get some junk. May or may not reflect what the problem is. So, negative culture, helpful. A positive culture, you have to ask yourself, was it done correctly? Is that my likely focus? Right. Chest X-ray, not really useful. I would always go for a CT scan, HRCT directly for my profoundly neutropenic. Why? Because if an X-ray is normal, it doesn't exclude anything, you need a HRCT. If his X-ray is abnormal, you need to know what's happening, so you need a HRCT. I think it's fairly easy. Just no contrast. So don't worry about the kidney. Just do a plain HR. If you again, I'm not suggesting you send the patient every day for a HRCT. First 2-3 days, if there are no pulmonary symptoms, you don't need X-ray. Patient is stable, that is. By day 4, patient is not getting better, things are not turning the corner, then get a plain HR straight away. That's the way we were taught. I was taught when I was in Karmana, so in the sun. All right. All these things, right? Identify every possible focus of infection, right? And of course, like she said, the symptomatology may be muted. You have no neutrophils. You have no neutrophils. Symptomatology will be muted, so don't expect a big song and dance for everything that's happening. You have to look for it. All right. So urinalysis is unhelpful in neutropenia. I said this. Chest X-ray is unhelpful. And of course, repeat examination every day. Right? There's no simple way of putting this. You have to examine the patient head to toe every day, again and again and again. The patient may get irritated with you. That means you're doing a good job. So how do you handle high-risk patients? Well, I would say in our country, even for low-risk patients, sometimes we are stuck with BLBLI or a carbapenem. Why? Because our baseline itself is ESBL. Let me put it like this. ESBL is a good day. Right? Because a bad day is carbapenem resistance. Or even worse. Right? So, you start with either a BLBLI or carbapenem, depending on the situation. Patient is in sepsis, septic shock, critical, or a high-risk patient, you probably start with a carbapenem. Stable, low-risk patient, you probably start with a BLBLI and then decide. If you have mucositis or you think a line is involved, things like that, you add an MRSA cover, Vanco, Tico, whatever your favorite poison is. And then you start escalating if the patient is worsening or the person is not really improving in spite of measures. But then you have to start with assessing why the patient is not improving. No, not this. Okay. I do this. Okay. Of course, if the patient is improving, always try and see, can you minimize stuff? We'll talk about that in a minute. Go on. Okay. So we talked about this piptazo or cephalosporin sulbactam or imipenem, meropenem. Aminoglycosides, not perfect drugs, great for urinary infection, great for line-related infection, not great for lung, not great for CNS, right? So if you think a gram-negative in the line, you can think of an aminoglycoside as an adjunct. Not great as an add-on for MRSA because it really doesn't improve outcomes. Vancomycin, obviously, Vanco or Tico or whatever your poison is for MRSA, yes. So when do I think of BLBLI? If I don't have significant prior antibiotic use, there is no prior MDRO, relatively short duration of neutropenia, not very critically ill, and no high-risk factors. This is the kind of patient where I would think of a BLBLI. If the patient is violating any of those, I'd start with a carbapenem first and then de-escalate. But then if the person is worse, if he already has a MDRO, I'd have to start even higher than meropenem. Okay. So when do I think of gram-positive cover? Hypotension, concern is about line, severe mucositis, respiratory focus, or a persistent fever. I'll put a star over the persistent fever because the correct answer there is actually reevaluate the patient to see if there's something else happening. Go on. Should we use colistin or polymyxin? Now, of course, more and more people are moving to other drugs like ceftazidime, but polymyxin, I remember when Chandra was here a couple of years ago. Dr. Chandrasekhar is our godfather for infectious disease in this country. And I was talking about this particular issue, and I said, we should use colistin early if the patient is sick and all that. He was horrified. How can you say things like that? Because renal injury in an oncology patient, especially hem-onc, is like a death sentence. But here's my point. Septic shock kills more people. Right? I can dialyze the kidney. I can't bring back a dead patient. right? So the point was give colistin, and everybody piled on and said, no, we should give colistin. He was looking at us like, what is happening? Then he looked at the microbiology and he was like, yeah, okay, it makes sense. It's sad, but that's what it is. See, they now understand what our problems are because our epidemiology and our microbiology is very, very different. So yes, we would think of colistin if the patient is clearly worsening on a carbapenem-based regimen, especially if we're expecting an MDRO. But if you're expecting an MDRO, start with an MDRO cover and then come down. But also get the cultures, please. Okay, so let's look at the data from India. This is from, I think, Kidwai, Bangalore is Kidwai, Vellore is CMC, Rishikesh, I don't know which one it is. So as you can see, AIIMS Rishikesh must be, okay. So data over the years, as you can see, a lot of gram positives, a lot of gram negatives, but look at the carbapenem resistance. The newer data seems to suggest more carbapenem resistance, right? That's really creepy. That's really, really creepy. Today, for experienced oncology patients, carbapenem resistance is to be expected, right? First admission is a different one. But let's say this guy has been getting repeated cycles of chemo and whatnot, and he's been coming in and out. Think of your dialysis patients. These are all patients who are in and out again and again. They are all harboring MDROs. So, yeah. Yeah. So, Kidwai showed that their susceptibility profile over 2 to 4 years has been slipping. Their antibiotics are working less well. This is 10 years ago. Now, if you look at it, it will look even worse. I'm good. What about the rest of Asia? This is from various other countries, some of it being in our neighborhood. And as you can see, even there, they're talking about ESBL and carbapenem resistance. So this is a phenomenon across Asia. It's just that we are way ahead, right? Unfortunately, we're not going to get an Olympic medal for this, right? So how do you know which patient has got an MDRO? Well, rectal colonization. Again, not everybody does this. Stool cultures used to be a big thing. More and more centers are giving up on that, just like Levoflox. In the Asian Myeloma Network, that also came up. Almost every center, hem-onc center in the private sector has stopped using quinolone prophylaxis. Doesn't work. So, rectal colonization, more severe than neutropenia, patient on mechanical ventilation, patient already on broad spectrum antibiotics, more intensive chemotherapy, longer ICU stay, longer hospital stay, prior MDRO colonization. You know what? These all tell you that the patient has already got the MDRO, right? And what does reduce the risk is being sensible about antibiotic use. See, I explain it like this. It's like a child with a toy. If the child plays with the toy long enough, the child will break the toy. Yes or no? So put the toy down. Right? You're not doing any favors by giving more antibiotics. I am not suggesting you give inadequate doses. I am not suggesting you not start where you should. Start high, start aggressive, de-escalate and stop. And when you stop, it's not like, I've given meropenem, why don't you give piptas for a few more days? No. If you can de-escalate piptas, you de-escalate piptas. You finish the course, done. No antibiotics after that. Right? You're only interested in shooting that particular thing, not spraying around and killing some innocent bystanders on the side. Right. So this is where we are. Ceftazidime-avibactam. Hematology oncology, that has shown to be superior to colistin-based therapy for CR Klebsiella and CR E. coli. Right? So if you have a carbapenem-resistant enterobacterial, colistin-based therapy is clearly inferior to ceftazidime. Now, in our country, let's say in a corporate sector, you have a patient who develops a neutropenic sepsis. What do you think they should use? Meropenem or ceftazidime-based therapy? Meropenem. So this is exactly the question my friend asked. So this was actually a study. This is the only study I've seen from India. 99 high-risk hematology oncology patients, AML, ALL, aplastic anemia, MDS, lymphomas, they had febrile neutropenia and they were randomly assigned to 3 treatment arms. Meropenem, ceftazidime with Astronam. Open label with clinical follow-up, right? This is the best you can do in India. This was actually done in a corporate center, right? So, what did he show? The first table is meropenem, ceftazidime, Astronam. What you can see is Meropenem had a much higher risk of going to the ICU as compared to the other arms. Going to the ICU for these patients is a bad thing. How many of you agree with that? Right? So that itself tells you that if you are on ceftazidime based therapy, you are less likely to end up in the ICU. We agree that's a good thing? And also look at this. Antibiotic change within 72 hours. The majority of patients who are started on meropenem had to be changed. Very few, much less of these had to be changed. The patients getting the least change was the ceftazidime avibactam group. Right? So basically it tells you that meropenem was not the right choice. Right? So these two data sets tell you that if you start meropenem, the chances are you will probably have to change it. If you start meropenem, your patient is more likely to go to the ICU. What else did he find? Completing the therapy based on what you started. Very few, 21%. The majority on ceftazidime completed it as they started it, right? And most people on meropenem had to have other drugs being added to them to try and rescue the patient. What else did he find? He found that again, ceftazidime seemed to have a ceftazidime based therapy had a trend towards better survival. But the point was the majority of patients who started on meropenem ended up getting ceftazidime in 72 hours later. So the take home, unfortunately, today in most corporate centers, if you have a high risk neutropenia, especially because our patients come in heavily experienced, is that you have to expect a CRO. Of course, the problem is this will not cover CRAB. But that's okay. We have ceftriaxone, that will fix everything. Let me make this very clear. There is nothing which will fix everything. Okay. We have an answer today. Tomorrow, the answer is likely to change. That's why they give a disclaimer. This is the opinion today. Opinion may not last tomorrow morning also. So, what do we do for modification? If the patient is well at 72 hours, you should be thinking of de-escalation and reducing medicines. Fever is never an indication to accelerate therapy. Patient is stable and just fever does not mean you are. I remember the days when I was in the CMC, we used to say, hematology used to come and every day something will get added. First day, meropenem, second day, vancomycin, third day, amphotericin B, and the fourth day, I don't know what. All kinds of stuff. Now we realize that that probably does not make much sense, right? If the patient is stable and the patient is not worsening, don't panic. Of course, if the patient is unstable, the rules go out of the window. You got to be a little more aggressive. Always modified by both clinical and microbiological data. Like she pointed out, your microbiological data may only reflect part of it. Her patient ended up having an abscess. When you have an abscess, you may have to cover for things which you did not pick up in the blood culture. Make sense? So keep that in mind. That doesn't mean you give broad spectrum extra antibiotics for everybody. Assess globally. Persistent fever always needs reevaluation. It doesn't need more antibiotics. Unstable patients obviously need help. If you don't think there's a risk of gram positives, get rid of vancomycin or teicoplanin, whichever it is. Extra costs, extra side effects, all that stuff. Antifungals, you start thinking about it beyond 4 to 7 days. She talked about it. I'm not going to go too much into it. Let's see. When do we stop therapy? You started antibiotics, patient is getting better. Can you stop antibiotics? How long do you need to give? 14 days. We used to think it is 14 days. No longer. So now more and more people are talking about afebrile for more than 24 hours and marrow's recovery. See, it's easier if the marrow is recovering. We agree with that? It's a problem when the marrow is not recovering. If the marrow is not, see, if it is afebrile marrow recovering, you can stop. If the patient is afebrile and the cultures are negative and the low risk situation, you can still stop. Let's talk about AML, high risk situation. AML, patient has become afebrile, marrow is going to take time to respond. What do you do? That is where you need to be careful. So, in high risk, we used to say we have to give at least 14 days of therapy, or if the neutrophil count starts recovering beyond 500. But that is changing now. That guideline is changing now, and more studies are coming. Not really great quality studies, But lots of retrospective data is now starting to say that if they are afebrile for at least 72 hours and the patient is otherwise doing well, even in a high risk patient, it's okay to stop antibiotics. Otherwise, the patient is going to end up on antibiotics for 21 days, 28 days also. It doesn't make sense. You're not helping yourself, you're just creating more trouble. Because the next sepsis that happens, you'll have to, the only answer you'll have is prayer. Right. So this is the forest plot of shorter therapy versus longer therapy. No difference. Outcomes are not different. Actually, now one thing you should understand is in many corporate sectors, in the transplant groups, both solid organ and stem cell, we are starting to see C. diff as a significant problem. Clostridium difficile is now a significant problem, and antibiotic use is the major driver. And Clostridium difficile in stem cell transplant is a nightmare. Recurrences are common, complications are common. There are people doing FMT. I think Parikshit has done more than a dozen or something? Oh, right? Yeah, that's the kind of transplant we guys do. Right? So I told my administration, I'm also a transplant physician. But the good news is this transplantation doesn't need immunosuppression. This transplantation needs stopping antibiotics, which also we guys love. Right. So this is from last year's that cancer journal where they looked at short duration, long duration. There's really no difference in the mortality rate. Really no difference in the mortality rate. But again, the quality of evidence is not the best. But there is more and more of a trend towards going towards shorter duration of therapy, and it makes sense because you have less complications at the back end. Antifungal therapy, we talk about this. We think about it in very high risk patients, especially AML. We used to think ALL was nice. But now, you guys do some really horrible stuff like the BFM regimen, Berlin, Frankfurt, Munster. We find innovative ways of assaulting the patient's immune system. Right? I mean, we are trying to do good. Don't get me wrong. But the problem is that at the end of it, you have a protoplasm which is unable to defend itself. Ibrutinib, terrible drug when it comes to fungal infection. I suppose it improves outcomes. I'm not debating that. But, it's a nightmare when you have a problem. So, like alemtuzumab, we call it AIDS in a bottle. Right? So, you should, we can come up with some really cool lingo for all this stuff. So, relapse, HSCT, all these things you got to be careful. When I say do not use serum galactomannan, do not use serum galactomannan blindly. You have to understand the setting because the galactomannan comes up high. You don't know what to do with it. First, have a syndrome, then ask for markers. Should not be the other way around. Okay. Beta-glucan, absolutely no. Serum PCRs, I know there's a lot of tests being done right now, everything being peddled. We don't know how they perform. Anyway, he will talk about it. I'm not going to worry about it. CT lungs, yes, at 4 days, definitely. And if there are symptoms here, I would definitely also scan the sinuses here. Routinely scanning the sinuses is really low value. Always, even if you're giving antifungal therapy, look for foci and make sure you're evaluating that. Prophylaxis. Oh, okay. Most guidelines only recommend prophylaxis in those who are considered high risk. So routinely giving prophylaxis doesn't make sense. Fluoroquinolone prophylaxis, if the neutropenia is going to be there for at least 7 days, but in our country, it doesn't make sense. Corporate sectors, almost everybody has stopped. CMC, Tata, you think of all the big oncology center, hem-onc centers, even Apollo, everybody has stopped using quinolones. No point, right? You want to have chicken to, Cipro today, just have chicken. You will get your Cipro. Cotrimoxazole prophylaxis, especially for those who are getting steroids for more than 20 milligrams equivalent for at least 2-3 weeks or more, you should think about it. Funeral analogs, that's something we often forget. Entecavir if the patient has got hepatitis B, because otherwise you don't want a flare of hepatitis B happening. Core antibody positive, surface antigen negative is another curious situation. That, of course, is a whole different discussion. She talked about this. I'm not going to go into this. Again, she said this. Do not try to preserve the line if you have a tunnel infection, pocket infection, persistent infection, atypical mycobacteria, candida, difficult to treat organisms, things like that. Right? I'll give you an example. Let's say you have candida albicans. Precious line, you're trying to lock it with an echinocandin. It may work. I'm not saying no. But candida auris Even if it is susceptible to echinocandins, it won't work because there's a difference between what we call the sessile forms and the planktonic forms. Right? In biofilm, they can drive up their MICs tremendously. What you see is MICs in the blood. They are not the same as MICs in the biofilm. Right? So keep that in mind. You can't just, it's not like how our pharma industry does. Take one beta-lactam, take another beta-lactamase inhibitor. It doesn't matter what they are. Slap them together and say, voila. Right? No, we don't do stuff like that. And okay, prevention, this is absolutely critical. The first thing is improve the air quality. There is something called ICRA, Infection Control Risk Assessment Guidelines, right? Any structural work anywhere in the campus increase the risk of fungal infection, right? Instead of trying to do, throw drugs at the patient, try to improve the air quality. I know it's not HEP, and most people don't understand because they can't see it. This problem has persisted since the time of Semmelweis. Please. And see, the problem is you can put them in a HEPA filtered room. What do you do if they need a CT scan? There you go, right? You can't bring the HEPA CT scan into his room, right? You take the patient out. That makes sense. And if your fungal load is very high, it can overload the HEPA as well. And when was the last time the HEPA was evaluated for functionality? There you go. So please keep that in mind. Food, of course, cook it, peel it, forget it. I love that. Water, make sure water quality is good. Contact precautions. And of course, she talked about it. I think we also have a vicarious liability in terms of taking care of the patient's health. Please take the flu vaccine for yourself. I think that's about it. Pre-transplant screening and prophylaxis. Okay. So, summarizing, starting therapy high is critical, but de-escalation is imperative. Risk stratified to help you decide where you will go. Repeat exams every day. Regular escalation for fever is not an answer. Check the local antibiogram, talk to your microbiologist and understand what your pathogens are and where you need to start. Please strengthen your HIC practices. She talked about this. Granulocyte infusion, so I'm not going to talk about it. And that's about as much as I have. Thank you. Okay. Here, you can use this. Any data for ticarcillin? Okay. Ticarcillin by itself is not a very useful drug. You'd have to combine it with clavulanate for it to be effective. Unfortunately, most of the guidelines focus on piperacillin tazobactam, and in India, probably ceftazidime. The volume of data that we have with ticarcillin clavulanate is much less. So, is it anti-pseudomonal? Yeah, you can say that, but most people will be uncomfortable using it. And as a beta-lactamase inhibitor, clavulanate is not in the same league as, say, sulbactam and tazobactam. So I would not use ticarcillin clavulanate as an option. I'll tell you where I would use it: Stenotrophomonas and things like that. There are specific situations that ticarclav could be helpful. But as a general rule, will it be better than what we have? The answer is no.
My question is, when we have an organism which comes everything resistant, like everything is resistant. Now we don't know whether it's a commensal or whether it's actually the one which is causing bacteremia, right? So how do you deal?
Sure. So never start with microbiology. Always start clinically. What is your diagnosis? Microbiology cannot tell you your diagnosis. For example, 10 power 5 urinary concentration of organisms. Do a simple experiment. Okay. Ask a patient to give you a urine sample. Send it straight to the lab and ask them to process it immediately. Nice warm summer day. Keep it outside for 4 hours and then send it. The colony count would have gone up astronomically. Now, where is this 10 power 5? See, understand that there's a lot of pre-analytics which go into it. How was the sample collected? How was it stored? How was it transported? If you don't analyze all of these things, whatever data you're getting is garbage. So always start with your diagnosis. Clinically, what do you think is the focus? If it is in the blood, you do not think of contamination. Coagulation negative staph, coronary bacteria, possible. But otherwise, even those things become relevant when you have lines. So always ask yourself, do I clinically think this is a focus? B, Is this a highly virulent pathogen which is capable of causing infection? Like you do a filaria and you get influenza. You do not ignore that, right? But just finding some random PCR or random bacteria, you have to ask yourself, does this fit in with what the patient has? Does this make sense? If the answer is no, look a little harder, dig a little deeper. Maybe there's something you're missing, or maybe this is garbage. So please don't get into the trap of accepting anything that microbiology throws at you as gospel truth. You have to analyze and see what is the pre-test probability and therefore what is the post-test probability. Nambi, anyway, we'll talk about that in more detail, I suppose. Thank you.